into erythropoietin therapy, EPO.
Yeah, we've got this clinical flowchart as our guide.
Exactly. Think of this as your, quick guide to the essentials.
Yeah.
We want to trace how this therapy works step by step.
From giving the drug to what it does, how we check it's working.
And the potential problems, too. We'll follow the flowchart point by point. Really helpful for your studies.
Okay, so first up is administration, how you actually give it.
All right. The source material mentions EPO or its cousins like epoetin alpha.
Like darbepoetin alpha.
Yeah.
Yeah. They can be given subcutaneous under the skin or IV, intravenous.
And they come in like pre-filled syringes or vials.
That's usually how they're packaged, yeah. Makes it easier.
So it's given, then what? Where does it head?
Well, it gets absorbed. Subcutaneous is slower, more gradual, good for a sustained effect.
And for?
Much faster. Often used if someone's already getting, say, hemodialysis. Makes sense to piggyback it.
So once it's circulating, its main destination is the bone marrow.
The bone marrow, absolutely. That's the red blood cell factory.
The factory, right?
And there it connects with specific docking points, erythropoietin receptors, EPOR, on the early red blood cell precursors.
Okay, so it docks. What message does that send? What's the core action here?
The core action is stimulating erythropoiesis. That's the fancy term for making red blood cells.
Ramping up production.
Exactly. It tells those precursor cells to survive longer, multiply more, and, specialize faster into becoming red cells.
And it boosts hemoglobin synthesis, too, the oxygen carrier.
Yes, increases hemoglobin and helps them mature into reticulocytes, which are the nearly mature red cells.
So the bone marrow starts pumping out more?
Precisely. You see a rise in reticulocytes in the blood first. The source says usually within, 7 to 10 days?
It's about a week to 10 days.
But the main goal, the increase in mature red cells measured by hemoglobin and hematocrit, that takes a bit longer, weeks usually.
And the benefit for the patient, the therapeutic effect.
It's all about correcting anemia. Really important for patients with chronic kidney disease or those on chemo, certain HIV therapies.
And correcting that anemia means less fatigue, better energy.
Definitely. Improvement in fatigue, pallor, that washed out look, exercise tolerance goes up, sometimes even cognitive function improves. It can make a big difference to quality of life.
Sounds great, but it also sounds powerful. Monitoring must be key.
Oh, absolutely critical.
Yeah.
Non-negotiable. You watch the patient, their symptoms, and definitely their blood pressure.
Blood pressure? Okay. And lab tests.
Central labs are hemoglobin and hematocrit, obviously, reticulocyte count to check the response, and crucially, iron studies.
Ah, iron. Why is that so central? What exactly are we checking?
Because iron is fundamental. You can't make hemoglobin without it. So you check serum ferritin, that's the iron stores, and transferrin saturation, which is like the iron available right now.
Got it. And there's a target range for hemoglobin.
Yeah, the source highlights aiming for 10 to 12 GDL.
10 to...
And here's a really key point for you, KMR advised viewers. The source warns against going above 12 GDL. Avoid exceeding 12.
That upper limit sounds serious. Why the strict warning? This must lead into the risks, the adverse effects.
It does. Pushing HB too high or letting it rise too quickly increases danger. The most common issue is hypertension, high blood pressure.
Okay, hypertension. What else?
More serious are thromboembolic events. Blood clots, think DVT, stroke, heart attack. The risk goes up significantly if you overshoot that HB target.
Wow, okay, so clots are a major concern. Anything else?
There's a rare but serious thing called pure red cell aplasia, PRCA, where the body attacks its own EPO or the drug. And, minor stuff like injection site pain or feeling a bit flu-like sometimes.
You mentioned iron earlier. Is managing iron deficiency a big part of this?
Absolutely vital. The source stresses you must correct iron deficiency, often means giving iron supplements. You also need to check for and treat folate or B12 deficiencies if they exist.
Right, and dosing isn't one size fits all.
No. Definitely needs adjusting for different groups. Kidney patients, cancer patients, kids.
What if someone just doesn't respond well? Is resistance a thing?
It can be. The flowchart mentions common causes. Iron deficiency that isn't fixed, ongoing inflammation or infection, maybe aluminum toxicity, poor nutrition. If the HB isn't rising, you need to investigate these possibilities.
And just letting the HB rise too much is itself listed as a complication, right? Because of those cardiovascular risks.
Exactly. Excessive rise increases risk of clots, seizures even. It's all about careful control.
So this flowchart really maps out the whole journey. Drug administration, mechanism, benefits, but also very careful monitoring and managing all these potential issues.
It's a complete pathway, really. Understanding each step, the targets, the warnings, It's essential for using EPO safely and effectively.
Well, hopefully, this deep dive, following the source material, has given all you KMR advised viewers a clearer picture of EPO therapy steps and challenges.
It really brings up a core clinical question, doesn't it?
Mhm.
How do you balance using such a powerful tool to relieve anemia and improve lives against the real risks, like hypertension and clots? That balancing act is constant in medicine.
Absolutely. A great point to consider further. For more deep dives like this one here on KMR Advice, please do share the video, subscribe if you haven't, and hit that notification bell so you don't miss our next one.